I'd ask the second panel to come forward. As they're coming forward, I'll introduce the second panel. We have Dr. Powell, who's the President and Chief Medical Officer and co-founder of Airstrip Technologies in Texas. We have Rick Dawson, who's President and Chair and Board of Directors of Continua Health Alliance in Texas. We have Kent Dix, who's Chief Executive Officer and Chairman and founder of MedApps in Arizona. We have Dan Frank, who's the Managing Partner of 3 Wire System, LLC in Virginia, and also on behalf, he's here on behalf of MHN. And we have John Mize, who's Director of LifeWatch Services in Illinois, and I'll turn it over to Mr. Miller to introduce one of his constituents.
You turned it over to me because you couldn't pronounce his name.
That's correct.
Thank you very much, Mr. Chairman. It's a pleasure for me to introduce to the subcommittee today Dr. Hugh Nguyen. He is a constituent of mine from Pensacola. He serves as CEO of Cogent Systems. Cogent is setting a higher standard in health information technology, bringing forth expertise on a topic of great importance to the VA committee, electronic record sharing. Cogent has already demonstrated success with DoD. At Naval Hospital, Pensacola, they're currently evaluating their system and securely sharing information with other local hospitals in the area. As a Navy veteran in Iraq himself, he was well aware of the many needs and shortcomings of DoD and VA in their systems, and his knowledge will be valuable to this committee as we keep seeking to improve services for our veterans. By demonstrating that a virtual health network can exist and at the same time safeguard information, Cogent, under Dr. Nguyen's leadership, has taken a step where I and many other members of Congress wish to see VA and DoD go. The electronic record, formed during a soldier's service under DoD and immediately transitioned to VA upon separation from active duty, is long overdue. Not only will it ensure easier enrollment into the VA health care system, it will also help bring a better quality of care when those soldiers do in fact enroll. I thank Hugh for his contributions to our active duty military and veterans community, and I thank you, Mr. Chairman, for agreeing to have him here to share his insight with your subcommittee.
Thank you very much, Mr. Miller. And I'd also remind this panel, because the votes will be coming up, we'll try to stick to the 5-minute rule as well. We'll start off with Dr. Powell.
Thank you. Good morning, Chairman Michel and Ranking Member Brown and distinguished members of the House Committee on Veteran Affairs. My name is Cameron Powell. I'm actually an OBGYN physician by training and the co-founder of Airstrip Technologies. We are a healthcare IT-based medical software development company based out of San Antonio, Texas. And our technology actually improves patient safety and reduces risk and improves access to care, specifically by delivering real-time critical patient data through the cell phone network and wireless networks to mobile devices such as the iPhone, with a real focus on patient monitoring data such as waveform data. And interestingly, this morning there has already been a lot of discussion about women's health and perinatal care, specifically referencing the triplets earlier in the Angel Network in Arkansas. And actually our first product using our own technology that we developed, Airstrip OB, is one of the only FDA-cleared applications on these mobile devices. It's currently approaching about 200 hospital installations around the United States. And every day we have thousands of doctors relying on this real-time critical access to these babies' heart tracings to try and prevent adverse outcomes from occurring in obstetrics. And we just started in obstetrics. Soon we will be unveiling our critical care and cardiology applications. But I think, as we all know, in the U.S., we have a lot of problems in our healthcare system. And one of the core problems that we are focused on that's facing healthcare professionals is this increasing disparity between a growing number of patients that need to be monitored in any environment and a relative decreasing number of doctors and nurses that can actually monitor them. So what we're all focused on, right, at the end of the day, is trying to figure out how do we get, in a timely fashion, the right data about the right patient to the right doctor or nurse at the right time to try and affect a positive outcome. So remote patient monitoring of critical patient data using these devices, iPhone, BlackBerry, Android, iPad, is rapidly becoming a necessary technology within the healthcare IT space to try and better care for patients and improve outcomes, especially in rural communities. I want to briefly talk about several reasons that patient monitoring with mobile devices is important, and a few examples. So number one, doctors and nurses are a lot more mobile than we were 5-10 years ago. We're covering multiple hospitals, we're covering multiple environments, and we know that patient access to care in remote areas continues to be a problem. And with recent advancements in technology, there's been a paradigm shift in the healthcare community. There is an expectation now that technologies will allow healthcare providers to have access to this type of data, to the type of data that we deliver, which is this real-time critical waveform data and other types of analytics and decision support data on demand, very fast, securely, in a HIPAA-compliant fashion onto a mobile device. And if we think about this growing disparity, the number one cause in the United States of patient injury, at least in a hospital, is communication errors. And as you have fewer physicians being able to take care of, or required to take care of more patients, the probability that communication errors will grow is there. It's going to happen, and this shortage is not going to get better anytime soon. So if you can, through wireless technologies, if you can close the communication gap and you can deliver that critical data on demand to a healthcare provider to help them make a better decision about a patient or what to do about a patient in a situation, then you have hopefully tried to reduce that risk. And so we are working to solve this problem by inventing this Airstrip technology. And of course, we first went after the obstetrical market, but now our application is looking to apply across both women's health, all of inpatient monitoring, the ICU, the operating room, the ER, but also into the home health space in rural communities. And some of the technologies that we hear about here today are people that are either our partners or are becoming our partners as we take that data that's being generated in the home or in the rural environment and display it very rapidly on the mobile device to help the physician and the healthcare providers make a difference. And I want to speak a little bit about the type of data. You get numbers and vital signs, it's important. But there are specific types of data that require visual interpretation. We talked, again, earlier about obstetrics and a fetal heart tracing. The way we make decisions is based visually on how this data changes over time, in real time, and historically. So if you're able to take that critical waveform data and provide it to a physician anytime, anywhere, we have hundreds and hundreds and hundreds of physician testimonials talking to us, telling us about how this has helped to avoid a bad outcome. So I think we're at a very exciting place with our technology. We're considered agnostic to the market, so we are either partnered with or looking to partner with multiple patient monitoring companies, health information systems, EMR vendors to effectively mobilize all of that data and at the end of the day try and improve outcomes by this type of compelling delivery system. And I think my time is up.
Thank you very much, Mr. Dawson.
Good morning, Chairman Michaud. Distinguished members of the House Committee on Veterans Affairs. My name is Rick Knaus, and I'm the president of the Continua Health Alliance. On behalf of the members of the Alliance, it's my privilege to be here to testify in front of you on this very important issue. The Continua Health Alliance is an international open nonprofit company, has about 237 companies at this point, and we're striving to put together an ecosystem of interoperable, standards-based personal health technologies like the ones you're hearing about. It's similar to the Wi-Fi Alliance and what they've done for Wi-Fi. We're trying to do that for personal health solutions. It's shown that standards-based solutions like that provide better quality, lower cost, and higher innovation, and so that's what we're doing. We've been at it for about 4 years, and we're making good traction. We have certified products from A&D, SciPac, Intel, Nonin, Omron, Panasonic, Roche, TI, and Toshiba. And we have several mobile developments from the likes of Cambridge Consultants, MedApps, Qualcomm, and BigNet. And also IBM and Oracle are looking at how we can integrate into EHRs. In Continua, we use a term called e-care, and I'd like to define that for you. It's the class of health information technologies that can facilitate the kind of virtual visit or electronic connectivity outside of traditional office visits. This can include in-home or mobile broadband devices, secure text messaging, or video teleconferencing. There are 4 benefits of e-care I'd like to point out. First being tools and education, like we heard in some of the earlier comments. E-care provides the opportunity to let people understand their disease better with education and also tools that they can see the results of their lifestyle. And hopefully those tools provide motivation so that they can keep taking their medication, keep doing the things they're doing to show improvements. The second one is collecting vital signs data dynamically. Instead of going to the doctor's office once every 6 months, taking a single blood pressure reading, we now have the opportunity to take it on a regular basis in order to provide a much richer compilation of data in which a doctor can make a diagnosis. Also, if something were to happen, we can detect that and take action on it now, not 6 months from now. The third is to facilitate virtual visits between the provider and the patient so that we can provide this when it's needed and where it's needed, particularly for veterans that might be in rural areas. And the last one, we provide social support networking so we can extend the family of care beyond just the hospital to include friends and families where appropriate or people with the same type of disease that might be halfway across the world. There's plenty of evidence about this. You've heard of some of them, NEHI and the VA. There's reports out that show great quality of care for much lower costs. You can see why we're excited about e-care. The Congress also recognized the value of e-care. In the Health Reform Bill, they have about 20 different references to programs that include e-care. I'll just list a few. The Accountable Care Organizations for Community-Based Collaborative Care Networks, the Independence at Home Demonstration Project, the Medicaid Health Home, and the CMS Innovation Center. All of these call out technologies that could be categorized as e-care. Very important. In order for the veterans and their families to realize the benefits of e-care that we've been talking about, the Continua Alliance has the following, respectfully submits the following recommendations, 5 of them. First one, integrate e-care into CMS reimbursement policy. Right now, out of the $468 billion budget, Medicare pays $2 million for telehealth, or 0.00005%. We feel like if procedures and services can be offered with e-care, they should be reimbursed as well. Second one, establish blueprints for the use of e-care in the states and in communities. One of the earlier questions talked about how we can leverage that. The VA has done a great job, and other places are doing good work. We want to not reinvent the wheel, but rather pull these blueprints together so that other communities can leverage it. Third, establish a federal organization focused on e-care. There are many organizations involved in this, including the FDA, ONC, FCC, and we feel like there should be an organized approach such that it's proceeding in a coupled fashion and we're learning from each other. Fourth, incorporate e-care as part of meaningful use. With the Healthcare Reform Bill and with ARRA, certainly we're going to have EHRs out there and becoming more broadly adopted. E-care provides the valuable data to populate those EHRs such that doctors can have rich information to draw on. And fifth, make broadband availability for all Americans a top priority. About 20% of Americans are not currently covered, including a lot of vets in rural areas. We can provide a much richer experience with that. In closing, we have a unique opportunity to enact change and extend care from the home in a manner to improve care and options for our veterans in a cost-efficient manner. We must take action through vision, leadership, and a national commitment to prepare for the demographic and economic changes that will bring changes to health care. American can be the leader in this, and we can start with the VA. Please let us know how we can work with the committee to make this possible. Thank you.
Thank you very much, Mr. Dix.
Good morning, Chairman Michaud, Ranking Member Billericus, and distinguished members of the House Committee on Veterans Affairs and Subcommittee on Health. My name is Kent Dix, founder and CEO of MedApps, a small business enterprise located in Scottsdale, Arizona. On behalf of the team of MedApps and the veteran-owned enterprise that manufactures our devices here in America, I would like to thank you for your opportunity to present this testimony. We are here today to speak about overcoming rural health care barriers through the use of innovative wireless health technology solutions. I am here today to talk about innovative digital wireless communications technologies like those produced by my company MedApps, which are quickly becoming a key component in the delivery of health care and services across America via wireless remote patient monitoring. Medical devices, health sensors, and their applications rely upon mobile broadband functionality, interoperability to transmit raw data, diagnostic health information, critical aspects of care, emergency services, and related health information. These services are at the forefront of a revolution in the provision and delivery of health care in America, a revolution which collapses time, space, and distance to more effectively monitor patients, develop analytic trends, maximize strained medical resources, and save lives. First, a word on the nomenclature surrounding wireless health. There are many terms loosely used today to describe the differing and often confusing aspects of wireless health information technology. For the purposes of today's hearing, I will use the term e-care, which is the term used by the Federal Communications Commission in Chapter 10 of the National Broadband Plan. E-care is the electronic exchange of information, electronic data, images, and video to aid in the practice of medicine and healthcare analytics. E-care is not a substitute for healthcare providers, physicians, or clinicians. It is intended to augment the good work of medical professionals. In a landmark comprehensive pilot with 17,000 veterans, the Department of Veterans Affairs demonstrated that by implementing remote patient monitoring, they experienced a reduction in hospitalizations by 25% at an average cost of $1,600 per patient per year for remote patient monitoring, compared to an annual cost of $13,121 per patient for primary care and $77,745 per patient for nursing home care. Amazingly, those encouraging results and statistics were achieved with the first generation of wired systems that are typically more costly, proprietary, and are tethered to a point of care lacking mobility. If the pilot program was able to achieve those encouraging results for patients using that technology, imagine the potential wireless e-care technologies would hold. E-care technologies like wireless mobile solutions drive down costs and improve care by closely monitoring patients wherever they may be. Thus, they allow healthcare to be practiced in more a proactive manner rather than a reactive manner, and can possibly head off a patient going to the emergency room or hospital setting in the first place. In my hand up here is our HealthPal. HealthPal is a technology, the sole purpose is to allow a patient to stay connected with their electronic health record and ultimately their caregiver. The HealthPal is FDA cleared and communicates wirelessly or wired with other medical devices, such as this known pulse oximeter, which takes your SpO2, and your heart rate as well. A doctor may ask a veteran with chronic obstructive pulmonary disease or congestive heart failure to take a reading once a day in order to make sure that they are staying within the safe zone. The HealthPal, like the one that I'm holding in the hand, has mobile cellular technology, M2M technology, like this M2M technology I hold in my hand today. The 3G mobile broadband chipset by Qualcomm is about the size of a quarter, which is embedded in the HealthPal and is the key to connecting our veterans to their healthcare providers in an efficient and economical manner. The HealthPal works as an agnostic hub or central device that connects to various medical devices and sensors and then transmits their data to a secure central server. The HealthPal comes packaged together, including mobile wireless connectivity straight out of the box, ready to use, nothing complicated to set up, provide, or maintain. Everything is done remotely, including software upgrades like the popular Kindle model. The MedApps solution is used in a variety of ways by everyday people, including David Jesse, a truck driver from rural Ohio. David's erratic schedule makes it difficult to set up and keep appointments with his doctor, and his health suffered because of it. David often had to produce logbooks to take to back to his doctor at the Cleveland Clinic every couple of months. His doctor attempted to adjust his medication based on the information. Today, David uses the HealthPal in the cab of his semi-truck, has taken his readings throughout 47 states. The technology has allowed David to substantially improve his health and need for medication. He no longer has to drive back to Ohio every 2 months to be checked by a doctor who, along with David's wife, can stay connected to remotely on the road, making sure he is okay and his medical conditions stay under control. At Meridian Health, a New Jersey health system, the technology is being used to help reduce readmissions of congestive heart failure patients. Typically across the country, 27% of congestive heart failure patients are admitted within 30 days with the same condition. An average CHF hospitalization is about $8,000. At Meridian Health, the HealthPal and a wireless scale are provided to a CHF patient upon discharge to monitor the patient every 30 days to ensure patients with the signs of worsening conditions are seen and their patients for early, less resource-intensive interventions. The equipment is returned to Meridian at the end of the 30-day period. So far, 30 patients from Meridian has experienced no readmission due to heart failure within the 30-day period. Thank you.
Thank you, Doctor.
Chairman Michaud, Ranking Member Brown, and distinguished members of the subcommittee, thank you for the opportunity to testify today. I also want to thank Representative Jeff Miller from my district for the introduction, and to note that he's been a leader in advancing the use of health information technology for veterans. My name is Dr. Hugh Nguyen. I'm a Navy veteran who served in Iraq in 2003 as a physician attached to the Fleet Hospital Pensacola. During that tumultuous period, I saw up close and personal the cost of war and the utmost sacrifices that our veterans make in the service of their country. I have since separated from active duty. However, I continue to serve our military and veteran community as a civilian emergency physician at Naval Hospital Pensacola. In addition to my military-affiliated duties, I am also the founder and CEO of Cogent Systems. Our mission at Cogent is to facilitate connected, value-driven healthcare. We achieve this by facilitating secure, web-based health information solutions leveraging cloud computing technology, which includes mobile technology. In my written testimony, I discussed a variety of mobile health issues. However, in my oral presentation, I would like to focus particularly on how health information exchanges can complement mobile technology by allowing comprehensive health information to be accessible on mobile devices. Secure mobile access to comprehensive health information can be particularly helpful to providers and veteran patients in rural communities. As context to today's testimony, I'd like to highlight a significant Veteran Administration objective that guides Cogent's desire to facilitate better care for veterans and in the process be a beacon for the greater civilian healthcare community. The Department of Defense Military Health System and Veteran Administration are promoting the Virtual Lifetime Electronic Record Initiative, otherwise known as VLER, which represents a major iteration of a new national capability to securely share electronic health information via the nationwide health information network. This is important in light of the fact that 3 out of every 4 veterans receive a portion of their care from civilian providers. President Obama has also stated that it is important, and I quote, allow healthcare providers access to service members and veteran health records in a secure and authorized way, regardless of whether that care is delivered in the private sector, Department of Defense, or VA. The TRICARE Health Information Exchange Project in Pensacola to facilitate the sharing of health information between military and civilian provider was a congressionally funded project. The basis of congressional support for this endeavor is due to the fact that by some estimate, more than 60% of health care delivered to DoD beneficiary is provided by private sector healthcare providers. Civilian providers are unable to access health information regarding a patient's status, health status or care from the MHS electronic health record system today. Similarly, civilian medical records concerning military beneficiaries are not available to MHS providers. In essence, we are practicing medicine in an information vacuum. This is the reality of patient care in military communities today. Our congressional funding for this project is fiscally managed by the MHS Telemedicine and Advanced Technology Research Center. To date, the project has successfully tested and deployed the largest instance of health information exchange between federal and civilian provider. The project entails sharing protected health information between Naval Hospital Pensacola and private sector healthcare providers in Pensacola by interfacing Cogent's health information platform with the DoD Veteran Administration Bidirectional Health Information Exchange, otherwise known as BHIE. Though not perfect, BHIE is the current health information exchange between the MHS and VA, and it is the largest health information exchange in our country and represents a significant investment on the part of both agencies. As far as I know, we are the only commercial entity that has been allowed to interoperate with the BHIE platform. So in Pensacola, more than 30,000 records concerning patients jointly seen by the MHS and Pensacola civilian providers can now be shared. This data exchange is in compliance with a data use agreement between our company and the MHS TRICARE Management Activity Office. Furthermore, the Pensacola community is finalizing a nationwide health information network data use and reciprocal support agreement as mandated to be part of any VLER demonstration. The Florida Gulf Coast boasts a large contingency of active duty and veterans. Escambia County in Florida is also fortunate not only to have Naval Hospital Pensacola, but also the Veterans Administration Joint Ambulatory Care Clinic. Both facilities are not only supportive of this health information exchange, they also play a significant role in the governance structure of the exchange. Because of the significant presence of the Veterans Administration in the Pensacola community, we believe that it is important for the VA to consider establishing Pensacola as a VA community. As health information becomes more interoperable, the potential for mobile health is limitless. Again, as a physician and a veteran, I'd like to thank this subcommittee for allowing me the opportunity to testify on a subject that is personally dear to me, the care of veterans. I hope that in my written and oral testimony I have established three things. One, the sharing of health information between MHS, the VA, and civilian providers, as envisioned by the VELA initiative, is important to coordinated care for our veterans. Two, this ambition to share information can be securely done today, as shown in Pensacola, as we migrate toward a nationwide network. Three, a health information platform and exchange can augment mobile technology in striving to serve isolated rural communities. The VA, in conjunction with the MHS, has enormous opportunity and responsibility to maximize its leadership in health information in order to take care of veterans. Thank you very much.
Thank you, Mr. Frank.
Mr. Chairman and distinguished members of the committee, thank you for the opportunity to testify on the use of wireless technology to overcome rural health barriers. My name is Dan Frank. I'm the managing partner of 3Wire Systems, LLC, a service-disabled veteran-owned small business. I'm joined by my colleague, Dr. Ian Schaefer, the Chief Medical Officer of MHN, a HealthNet behavioral health company. We are here today to talk about VetAdvisor, an innovative evidence-based program that provides mental health outreach, screening, and health coaching services to OEF, OIF veterans, their families in both urban and rural areas. VetAdvisor is a program which augments and supports existing VA behavioral health care services and assists veterans with challenges they face during reintegration into civilian life. It uses traditional and non-traditional telehealth delivery platforms to reach out to veterans and to improve their awareness of and access to mental health support for issues such as tobacco cessation, weight management, or understanding post-traumatic stress disorder management. VetAdvisor assists veterans and their families providing non-clinical health coaching services via telehealth platforms which allow veterans to focus on areas of concern to them without leaving their homes. The program identifies and works with veterans who have or are at risk for PTSD, depression, substance abuse, suicide, and homelessness. This telehealth approach to outreach, screening, and coaching helps eliminate the stigma veterans often associate with seeking mental health services and assists them in getting treatment. Health coaching services are provided to veterans through telephonic communication or virtual collaboration technology, which we call the VetAdvisor Virtual Room. In the virtual room, the veteran and the coach interact as avatars. This highly immersive virtual environment provides strong feedback that enhances collaboration and communication. Use of this virtual technology assists veterans in their reintegration efforts in a number of ways. First of all, it allows the veteran to discuss personal issues from the privacy of his or her own home or private setting of choice. Veterans may be more willing to acknowledge the magnitude of their issues in this private environment. Secondly, it saves the veteran time and travel costs associated with office visits by bringing non-clinical support virtually to them. And for today's internet-savvy generation of veterans and their families, this form of communication feels more natural than traditional communication methods. In the past, veterans who opted to use virtual room health coaching required wired broadband internet connectivity for their desktop or laptop computers to access this virtual world. However, veterans who reside in rural areas can face challenges acquiring such broadband services. Recognizing this limitation, VetAdvisor worked with our technology partners to leverage the most ubiquitous of consumer electronic devices, the mobile phone. Mobile devices will allow patients to wirelessly access health care as an important component in VA's transition to the patient-centered medical home model. To address this effort, VetAdvisor will launch a virtual world mobile phone capability, for example, an Apple iPhone, in the fall of 2010. By extending the virtual world to mobile phones, we can significantly increase the veteran user base in rural areas where broadband services is not available, but cellular service is. For veterans who opt not to use the virtual world, they simply may use their mobile phones to obtain health coaching services. We envision veterans using these mobile devices anywhere and anytime they desire to work with their health coach. So, for example, if you had a veteran who wanted to conduct a session with their health coach during their work lunch break, they could do that from their car, their office, or other location that provides privacy. The Vet Advisor program can be offered throughout VHA to ensure that veterans do not fall through the cracks. It provides VA with an effective mechanism to overcome access to care challenges in rural areas by using wireless solutions to provide outreach and ongoing support to veterans regardless of where they live. Without this program, many of these veterans might not return to VA to get the help they need or have as successful a return to their jobs, school, and families. On behalf of 3Wire and MHN HealthNet, we'd like to thank you again for your interest in the wireless capabilities of the Vet Advisor program and how we serve veterans and their families in geographically remote areas. We are grateful to the subcommittee for its leadership and commitment in identifying innovative programs that assist veterans. Thank you.
Thank you, Mr. Mice.
Chairman Michaud, Ranking Member Brown, and members of the subcommittee, thank you for the opportunity to testify this morning. LifeWatch is a health IT telemedicine company based in Rosemont, Illinois. We provide monitoring services nationally for over 15 years, and we represent the future of medicine in the United States. It is our privilege to serve the Department of Veterans Affairs in almost 40 facilities. Currently, our services help diagnose patients suffering from cardiac arrhythmia and obstructive sleep apnea in a near ambulatory and real-time environment. This virtual service environment is a launching pad for future disease-specific management of health data, supporting improved patient outcomes, continuity of care, reduction of emergency room visits, and unnecessary hospital readmissions. The LifeStar ambulatory cardiac telemetry service is based upon an algorithm that automatically detects and transmits via cellular networks clinically significant changes in heart rate and rhythm. I'm actually connected on the device right now. So, for example, if you're feeling dizzy, your cardiologist might prescribe our service to help diagnose what is causing the changes in your heart rate or heart rhythm. The VA Medical Center completes the physician's enrollment order to LifeWatch, and we in turn ship the device directly to the patient's house with all the necessary equipment. The LifeStar Act service increases the diagnostic yield compared to antiquated technology, increasing the likelihood that a diagnosis will be made and a treatment plan incorporated, which ultimately improves patient outcomes and reduces the cost of treating cardiovascular disease and stroke for the Department of Veterans Affairs. Additionally, the service allows veterans to remain in their home, reduces travel reimbursement expenses, and allows VA medical centers to shift employee resources to other responsibilities that cannot be provided in the home. The impact for rural veterans is even more pronounced in regards to cost savings, access to care, and improved outcomes. LifeWatch has also recently introduced a home sleep testing service for the diagnosis of obstructive sleep apnea. Wait times for sleep labs within many VA facilities exceed 6 months, and as a solution, many facilities utilize fee-service to push patients to commercial sleep labs at Medicare rates. Our service is less than half the price of utilizing a commercial sleep lab, stands to eliminate chronic patient waiting lists, and helps improve compliance as the testing is all done in the patient's home. According to a recent article published in the USA Today a couple weeks ago, veterans are 4 times more likely than other Americans to suffer from sleep apnea. About 5% of Americans suffer from sleep apnea compared to 20% of veterans. While there are many success stories, we've also had our fair share of struggles within the department. We are a GSA small business vendor, and despite our status on the schedule, procurement remains a struggle, necessitating contracting at the facility level. It can take upwards of 2 years for some facilities to finalize the budgeting and contracting process, despite clinicians' requests to utilize the beneficial service. We have seen some success with Project Hero as an in-network provider. The program appears to expedite the process and simplify procurement for facilities in the 4 VISNs under the demonstration project. Additionally, we've struggled with the lack of quality of care in terms of the standard of care for remote cardiac monitoring. In 2004, Medicare placed a requirement on remote cardiac monitoring, which included the necessity of providing 24-hour live attended coverage for patients wearing ambulatory cardiac devices. The VA does not follow the same standard across the board. Lastly, we have struggled with a lack of clarity on how to interface our data with Vista Imaging CPRS electronic medical records system within the VA. Multiple clinics have requested our data be interfaced, and in fact, many facilities will not use our service until we are interfaced. Despite the demand among cardiology, we've hit multiple roadblocks in terms of how to move forward. We are eager and ready to provide a secure interface with the Department of Veterans Affairs, which will most certainly improve the standard and efficiency of care for our veterans. Despite our challenges, we've still been impressed with the many facilities that utilize our wireless services. We also commend the Department of Veterans Affairs for their proactive approach to treating rural veterans with the use of telemedicine under the Office of Care Coordination. The VA is clearly a leader in delivering telemedicine. Mr. Chairman and members of the subcommittee, LifeWatch sincerely appreciates the opportunity to submit testimony and looks forward to working with you and your colleagues on improving the quality of care for our nation's veterans with the use of advanced technology. Thank you.
Thank you very much, and I'd like to thank each of you for your testimony this morning. Since the votes will be called very quickly and we still have one more panel, I'll submit my questions in writing. Hopefully I'll be able to answer them when you receive them. Mr. Bilirakis.
Thank you, Mr. Chairman, and I'd like to do the same. I'd like to submit my questions in writing as well.
Thank you. Mr. McNerney, any questions?
Well, thank you, Mr. Chairman. I feel a little bit pressure to do the same thing, but I just have one comment. You know, what you're saying, what everyone's saying, it sounds really great. The Veterans Administration or the veterans, a group of veterans is a great sample. It's a great group of people to try new technology on. But I also get a feeling inside that, you know, some of the technology is not going to work and some of our veterans are going to get hurt by the sort of the new technology is not done yet, that's not been tested out. Do any of you have any comment on that? Sure.
My personal feeling is that we're not really inventing new technology here, at least in our company, and a lot of us aren't doing that. It's technology that's already available today. We're just repackaging it. And I believe in healthcare, we're at the tipping point, to a point where it's causing them more harm to not be with the technology than to be without it. You let a disease exacerbate. You know, right now we're wasting taxpayers' money on a regular proportionate basis for not implementing this technology because they're in rural areas. You can't get them to the doctor on a regular time. They don't go to the doctor because it takes 2, 3, 4 hours to get there. Then it exacerbates to where it's an $8,000 emergency room visit. You want to try to put technology like this in place that's simple, that is accountable. It creates a sense of accountability for them to start following their doctor's orders, and that leads to compliance through them taking their medication and staying out of the hospital.
Okay, thank you. Briefly?
I'll just add real quick that the VA, through its history, has been an innovator in showing how technology can be used to control costs and care and increase care. And I think that is particularly important now that as we look in a world of healthcare reform. I mean, to me, as a physician, what I see very clearly is we're making a significant bet in our country that we can provide more Americans into structure-coordinated care and in the process save money. And I don't see how we can do that without leveraging innovations. And I think there are all the technology we're talking about today in most industry, finance and otherwise, has already been done. We're just trying to bring them into healthcare.
Okay. I didn't want to yield back to the chairman at this point.
Thank you. Mr. Snyder.
Yes, thank you, Mr. Chairman. Thank you, gentlemen, for being here. Why aren't there any women CEOs of these companies?
We have a women COO.
Oh, there you go. Yeah. It seems like we're perpetuating the problem of leaving women out of healthcare. I want to ask, in just one quick question, Mr. Nosson. Am I saying that right, Mr. Nosson? I was struck by one of the things that you said, which was, I think you used the example in your oral statement of a person may get a blood pressure reading every 6 months at home. Maybe just hear from you generally on the issue of, I don't think the goal for technology should not necessarily be just more information. It should be more helpful information. I mean, for years, if we had wanted blood pressures more often every 6 months, we just teach the person how to take the blood pressure daily, 4 times a day. I mean, 30 years ago, I sent a teenager home who was an early preeclamptic, and showed her how to take the blood pressure at age 16 because she was I thought, the only person in the household that really could handle that. And I got a phone call one night, said, Dr. Snyder, it's, whatever it was. And I went out the house and we sent her to the hospital and she delivered. So this is one of the issues that we have to make sure. We can overload our monitors, our doctors with too much information. I mean, I frankly don't know. I don't want to know what my heart's doing every minute. In fact, that's not what the studies on arrhythmia are based on. They're not based on constant monitoring. They're based on what is my blood pressure in 6 months, in 3 months, whatever it is. So I think that's an important distinction, is it not? We want helpful information that leads to proper decision making. We don't want to flood the system with information which may in fact not be helpful, but just flood the system. Mr. Nelson, I'll let you respond to that.
Sure, absolutely. And clinician acceptance is key to making these technologies become more readily available. What we need in addition to these technologies are some tools that take the data, aggregate it into graphs and trending, such that there aren't a bunch of data points, but rather an indication over time of what a reading would do. Personally, I have a little bit of hypertension, and since I'm an engineer, I use Excel spreadsheet and take my readings maybe 4 times a week, put them in a spreadsheet, and show that to my doctor. And he sort of looks at it, throws it away, and takes it with his own certified, blood pressure reading.
My kind of guy. Because information doesn't always lead to better outcomes. In fact, I can take some patients, and I mean, we all know that. I mean, maybe I'm one of those, and I can get them on edge. I can get them going to the emergency room frequently. I mean, the reality may be on your patient, the doctor may be saying 6 months is fine. We know that blood pressure is one of those things that kills people over years and decades, not over 6 months, and we need to be sure that we're using the technology to help outcomes. And flooding a doctor's office with information may not necessarily lead to better outcomes. That's part of, I think, what ongoing research will show. Mr. Miza's, using my bedroom as a sleep lab for greatly reduced cost, I think is the kind of technology that's helpful. Mr. Dixon.
Yeah, the one thing that we're really trying to do with this is not emphasize the technology. What we're trying to do is emphasize, compliance is an overused word, right? We don't want to try to create the CIA effect here, where you get rid of all the operatives in the field and you try to deluge with all the data there is, and nobody can make heads or tails of it. We want to keep the operatives in the fields. Those are the nurses, those are the doctor, and we want to provide them with clean data for them on a regular basis. But let's just talk about the technology. For the lowest cost possible, the flexibility, simplicity, all I'm trying to do is create a sense of accountability between the patient and the caregiver. So if that patient is knowing that somebody on the other end is looking for that reading to come in, they're more likely to take the reading, they're more likely to take the medication, and they're more likely to stay out of the hospital. So we're trying to put that sense of accountability in. We call it our technology 20% technology and about 80% psychology. All right? It's not about the technology. It's about that connectivity you have between the two and that accountability that you set up that's going to drive down healthcare costs.
Another issue, and my time's running out. I know to have votes come out. I'll say this as an MD. We're talking a lot here today about compliance with patients. Several of you up there, I guess Dr. Nguyen is the only physician there, Dr. Powell. The providers might benefit from these kinds of things, like an airline pilot checklist. We don't do that very well as providers. We think that a lot of us think, well, we're kind of magic. We just have a sense of it. And the reality is we would probably benefit from some of these technologies within the practice setting also. Thank you, Mr. Chairman.
Thank you very much, Mr. Snyder. Once again, I'd like to thank all of you for coming here today.